Good afternoon. My name is Carl Massonneau. It's an honor to be presenting today. I am a technical officer at the WHO Department of Sexual and Reproductive Health. I'm based in Geneva and specifically support the self-care portfolio of work under Mandela's leadership. It's an honor to be presenting today. I thank the organizer and in particular Dr. Tomokeshi, with whom I was in contact, for their invitation to the first annual meeting of the Japan Society of Crisis Management Medicine, which central theme and sub-themes are, can we be sapiens? And why can't we realize the achievement of science in society? Those questions are central to the dynamic work on self-care interventions for health and well-being WHO is supporting, and which has been led by Manjula Narasimhan, and that I will be introducing to you today with particular emphasis on humanitarian and fragile setting SRHR interventions. But first, let's recognize that there is a sense of urgency for health system to innovate in the way we deliver services and to power the resilience of ability of people to self-care beyond facility-based care. As we speak, half of the world population lacks access to essential health services. 100 million are being pushed into extreme poverty due to out-of-pocket health expenditure, and nearly 300 million people around the world need humanitarian assistance and protection due to conflict, climate emergencies, and other drivers. Harnessing evidence-based self-care intervention, inclusive of actions people can take and tools they can use to promote and maintain their health, prevent disease, and with or without the support of healthcare worker, will help. As such, the availability of COVID-19 self-test, HIV test, or pregnancy self-tests has allowed people to know their status and take appropriate action. In emergency setting, the use of emergency contraception can help women and girls who may have experienced rape to prevent an unintended pregnancy. In this presentation, I'll go through the WHO guideline, the associated conceptual framework, and introduce particular implementation consideration, as well as examples of self-care intervention implementation in humanitarian setting in SRHR. But first, let's start with the terminology. What is self-care? WHO defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness with or without the support of a healthcare worker. In this definition, it's important to highlight a few things. One is that self-care is recognized at the individual level, but also other social entities are acknowledged here, such as families and communities. Secondly, the self-care definition recognizes that self-care can be operated with or without the support of a healthcare worker, which emphasizes the idea of a continuum of care between self-care and facility-based care. From this broad definition of self-care, WHO defines self-care interventions as tools that support self-care, and these include over-the-counter drugs, medical devices, and diagnostic, some of which can be provided directly through digital platforms, but also a broader range of self-care actions, which include people actions, practices, habits, and lifestyle choices. It's important to acknowledge that in this context, self-care is often the first line of action for whole healthcare. It's a basis of this healthcare pyramid you can see here, because it's often an individual initial response to health and well-being needs, and it encompasses a wide range of activities that promote health and manage illness in daily life. Self-care, as such, is an important component of a comprehensive healthcare approach in complement of facility-based medical care and integrated to a continuum of care between primary, secondary, and tertiary care setting, as you can see on the left and on the right-hand side of the pyramid. Self-care intervention are associated with a high degree of autonomy and relatively low cost, as it can accommodate individual needs and preferences, and may be chosen due to convenience, cost, empowerment, or because they fit better with personal values or lifestyle. So the WHO consolidated guidelines on self-care interventions provide a pathway for health systems to better harness self-care. It was first released in 2019 and updated in 2022. Let's take a moment to recognize what a self-care guideline is. A WHO guideline is. The WHO guideline is the end product of a rigorous peer-reviewed process that includes evidence synthesis, expert consultation, and value and preference assessments. The WHO guideline on self-care interventions includes 39 recommendations in the area of self-care for sexual and reproductive health, but also communicable and non-communicable diseases. It also includes 18 good practice statements on the implementation of self-care interventions. I highlight here a couple of examples of self-care intervention in the area of sexual and reproductive health, such as self-monitoring of blood pressure and blood glucose during pregnancy, nutritional supplement during pregnancy, such as acids and iron supplements, self-injectable contraception, over-the-counter availability of contraception. It also includes self-collection of sample for STI, HIV self-testing, HPV self-sampling. It also includes things related to sexual health more broadly, such as the use of lubricant for sexual health in combination with condoms, of the self-administration of gender-affirming hormones. So what is the WHO approach to self-care? The first criticism to self-care is that it's often perceived as shifting the burden of care to the individual, self-care individuals being somehow more responsible for their own health. It's also criticized as a cheap substitute for professional health care and diverting the burden of care unfairly back into the informal, unpaid domain. This is not the approach that WHO supports. Self-care interventions alone can do much to achieve the desired health outcome. We need a comprehensive understanding of what a self-care model of care implies, and can to support the introduction, uptake, and scale-up of self-care intervention. This approach is underpinned by key principles of human rights, ethics, gender equality, which you can see in the pink circles. This principle emphasizes, for example, a holistic approach to self-care that considers not only the intervention itself, but the mental and environmental consideration associated with it. For example, self-care for mental health could be used in combination with specific antenatal care interventions. Ethical consideration are central to ensure fairness, equity, autonomy, privacy, and the protection of underserved population in accessing, using self-care intervention. We'll talk about later, for example, the need for privacy in using certain self-care intervention. The conceptual framework recognizes a life course approach, tailors self-care interventions to a need of individuals across different life stages, promoting equity, cost efficiency, and health literacy in the life course approach. Human rights and gender equality provides a basis to remove barriers to self-care, particularly for marginalized groups. Acknowledging that self-care intervention can be accessed outside formal health system, for example, through pharmacies, digital platforms, caregivers, or community centers. We need to recognize what are the enablers of self-care intervention to ensure access to justice, economic empowerment, education, protection from violence and discrimination, psychosocial support, and supportive laws to enable self-care. Improving health and digital literacy is vital for informed decision-making and the effective use of self-care intervention. Finally, accountability is essential at all levels, at the local, national level, and across a variety of stakeholders to uphold their responsibility and guarantee quality care, quality interventions, and promote better health outcomes. The WHO guidance for the implementation of self-care interventions. The WHO published a classification of self-care intervention that goes beyond recognizing what these interventions are as biomedical devices or action people can take. So there are a number of actions health system can do at different levels of the health system. I highlight here a couple of them for the different stakeholders that are recognized as agents of self-care. For example, interventions can take place for the self-care and caregivers, such as promoting awareness and demand generation around self-care intervention, or promoting agency to self-care. We discussed just before the importance of health literacy in self-caring. There are a number of actions that health worker can take, such as supporting people to develop strategies, self-care planning, to better include self-care interventions and actions into the lifestyle with evidence-based information. Health, a program manager can support in a variety of ways, including the registration of or the inclusion of self-care drugs and devices into a list of medical devices. Finally, health policy makers, legislators, and regulators play a key role to develop and evolve health policy to better incorporate self-care interventions, including within primary healthcare approaches. The approach that we took to develop this classification is problem-based. As we highlighted in introduction, there is a number of challenges that health systems are facing nowadays. It can be a shortage of health workforce or access to health issued because of cultural reasons. And matching those challenges, the classification lists what type of interventions beyond medical devices can be implemented to enable self-care. And it also recognizes what would be the place of access or the mode of delivery of such intervention to achieve the desired health outcome. In July 24, we published the first implementation guidance on self-care and well-being, which articulates the 18 implementation considerations and further expert discussions that have been conducted into a health system approach. And you can see here, recognize the health system pillar: information, health workforce, service delivery, leadership and governance, medical products, financing, research and evaluation. For each, the implementation guidance acknowledge what is the WHO recommendation, what are the resources available to guide and define that action, and also provide country example. Let's just take an example. WHO recommends self-care intervention that must be accompanied by accurate, understandable, actionable information, accessible in different format and language, about the intervention itself, but about also the link to relevant community or facility-based care services and the opportunity to interact with a healthcare worker or the trained peer supporter to support the decision around and the use of the intervention. Now, let's go through a couple of examples on advancing the role of self-care for SRHR in fragile and humanitarian settings. WHO recommends that we prioritize digital health services, but also self-care interventions and task sharing and outreach to ensure access to medicine, diagnostic devices, information, and counseling when facility-based provision of sexual and reproductive health services is disrupted. Also, WHO recommends maximizing occupational health and staff safety measures, including providing mental health care services and psychosocial support, and promoting self-care strategies among health staff. Let's look at the challenges that we face in a humanitarian setting that are common to all humanitarian settings, but also specific to self-care interventions. We see that there is always a diversity of crises and population, and we can be discussing refugees, asylum seekers, illegal immigrants, different settings as well, such as refugee camps, local communities, and different type of crises, acute, protracted, short-term, etc. And the cause of risk as well: armed conflict, climate change, pandemics may affect the complexity of the crisis, as well as the implementation strategy that we need to set up. We also need to acknowledge that refugees and displaced people are facing with multiple layers of stigma and discrimination related to accessing SRHR services in those settings. Specific to self-care, challenges are disruption to the local or national health system supply chain is a constant challenge in a humanitarian setting. Preventing stigma towards SRHR services is also a very important challenge in enabling self-care intervention. It's important to recognize that in crisis settings, survival takes priority over other health needs, and meeting basic needs such as access to safe space, food and water is critical to survival. Meanwhile, access to SRH services may be a low priority for disrupted healthcare system, yet the needs for such services are heightened because of the increased risk of unintended pregnancies and gender-based violence, to name a few. A common challenge to the implementation of self-care intervention in humanitarian setting is the burnout and overload of health workers that may be compromising the ability to deliver culturally appropriate care, including self-care interventions. Further, privacy and overcrowding is a common challenge, with overcrowded camp maybe making it difficult for individuals to use to have privacy for the self-care they need. Language and communication barrier is a constant challenge in humanitarian settings around the world, with refugees and displaced people encountering the communication barriers with a health and care provider from a different country, which complicates access to the service. Now, before we dive in examples, we can take a quick look at different enablers in humanitarian settings. There is a need for recognized need for multi-component strategies, recognizing that individual families and communities have diverse SRH needs, and they use the agency to meet their needs also may be different. The agency is a core component of people's ability to self-care. So it's important to understand how and when people use self-care to meet their needs. For example, health system failures in many settings mean that people freely access antibiotics over the counter from pharmacies, even though antibiotics should be available by prescription only. People navigate moral opposition, stigma, and discrimination in creative ways using self-care approaches. So we need to understand how users' knowledge, expertise, and existing self-care practices is key to implement and promote specific self-care interventions. And as such, multi-component strategies that acknowledge the different co-occurring social and health disparities may help to tailor our intervention to specific population. Also important is to recognize the importance of community engagement. So engaging with the community and establishing a sense of ownership is increasing people's sense of self-efficacy. Information and education is essential. Providing health-related information in multiple languages and avoiding jargon is essential for encouraging engagement and uptake of self-care intervention. Pictorial instructions are recognized to help clarify text instructions. Linkage to health system is essential. Although health system is disrupted, we need to streamline their use. And it's even more important to do so. Self-care intervention, again, should complement facility-based interventions, and strong linkage and referral pathways with the health system are necessary. And self-care as such needs to be part of a continuum of care that includes conventional, medical, and community-based care. The use of tools such as the patient journey, in this case, is often a practical way to understand how to streamline our interaction between self-care and facility-based care, recognizing what and how people self-care. We also need to acknowledge the importance of integration with humanitarian response framework broadly. Self-care intervention for sexual reproductive health needs to be linked to the H3 package, which is the high priority health services in humanitarian response, and which is used to inform the minimal initial service package MISP, which includes a number of self-care interventions, and we could serve as a basis to tailor our humanitarian response in the SRH field to better articulate self-care interventions. We also need to build with what we have, and existing self-care practices that are ongoing with marginalized and vulnerable communities, and as such, they may have practices that they practice before the crisis and may rely on them in situation where access to care is disrupted. And it's important to know about those practices and weaponize, if I may say, or harness them as in our self-care implementation strategies. Finally, a foundation to self-care interventions implementation in humanitarian setting is trust. Trust and social relation are essential to enable individuals to engage with healthcare services in disrupted settings. And here, it's important also just to mention quickly that we developed a competency framework that help us to articulate recommendation on self-care for the healthcare workforce, but also how the healthcare workforce can be an enabler of self-care instead of closing a possibility for people to self-care. So let's take a look at different examples. So in Kenya, we have over 500,000 refugees and asylum seekers, and 80% of this population is living in 2 counties. It's a very concentrated population in a very reduced number of camps. And these camps are facing strong climate-related challenges that includes extreme drought, heavy rainfall, and overall rising temperature. And there is literature to understand those linkages between these extreme weather events and heightened vulnerabilities in those communities. And among these critical risk that are faced by this community is the increasing risk of sexual and gender-based violence due to or active in those displaced population. And we see that there is an important number of transactional sex and increased exposure to sexually transmitting infection, which include HIV, trauma, and also substance use among those refugees. So in this specific setting, self-care interventions have been introduced to self-managed or over-the-counter access to emergency contraception, enabling post-exposure prophylaxis for HIV prevention, along with HIV self-testing, simple interventions such as pregnancy self-testing, and self-collection of sample for STI testing, also beyond HIV. So this intervention package was introduced to the community through local ownership strategies. And they emphasized the notion of empowerment of individuals, and in particular, women, to take control of their health. And they also used a holistic approach with by associating psychological first aid along those self-care solutions, and in particular, of course, for survivors of gender-based violence. Family planning is, of course, a constant challenge in refugee setting, also within community and social dynamics. So there are social pressures not to access family planning, and those are often associated with gender imbalances and restrictive cultural norms that often limit a woman's ability to make a reproductive choice. But we've seen that the distribution of the aforementioned intervention through kits named like safe motherhood kits to midwives or community health worker, also community members like the elders, created a good window opportunities to introduce and distribute those contraceptives and self-care products. And in combination with that distribution, they launched an awareness and knowledge campaign about family planning to improve decision-making and self-care practices. In this second example, we look at what are the SRHR needs and the potential for self-care intervention in conflict-affected communities in Ukraine and neighboring countries. So this is interesting because it's a stepped approach which describes, first assessing the needs and then assessing how self-care interventions can help us answering those and improving health outcome among specific population in different settings, so in country and also for population of refugees in neighboring countries. So just to give you an idea of the scale, there's over 5 million internally displaced people in Ukraine and 6.3 million refugees globally, and the majority of them are women and children. And this crisis, again, has intensified SRHR needs and in areas such as sexual and gender-based violence, safe abortion, HIV, STI, and maternal health care. So what was done is a rapid SRH assessment, which was conducted early in the conflict to acknowledge what are those exact pain points that we need to act on. And this rapid assessment led to the deployment of a minimum intervention service package, so the MIS package I mentioned earlier for SRH. And notably, through that minimal initial service package deployment, reproductive health kits were distributed to provide contraceptive, obstetrics and newborn care supply, post-rape treatment, STI medication, as well as clean delivery kit for women who were not able to access any facilities. And in distributing those kits, here local NGOs played a vital role to also raise awareness and ensuring that refugees and displaced individuals could access those services. But one remark from this implementation is that overall self-care interventions remained underutilized, and the challenges identified include the lack of provider training, the absence of local language instructions, and communication barriers between refugees and healthcare provider. And therefore, the key learning from this approach is to really focus on training healthcare worker, enhancing language accessibility in self-care tools, and strengthening community engagement. So in Cox's Bazar, strategies were deployed to address gender equality and SRHR needs through the provision of specific self-care interventions. So the Cox's Bazar, as you know, is the largest refugee camp with 1 million displaced Rohingyas, women and girls living there, and at increased risk of experiencing gender-based violence and unintended pregnancy and related complications. So the intervention package that was designed in this case include the self-management of medical, or emphasize on the self-management of medical abortion, which is called menstrual regulation in the Bangladeshi context. And the deployment model include assessment by a healthcare worker or community worker on the eligibility for the medical abortion and the monitoring of the first dose intake, the subsequent doses, and post-assessment of self-managed. And to complement this intervention package, they also emphasize the development of counseling material to enhance literacy and autonomy of women and girls seeking SRH services. The last example in the Asian region that I would like to highlight is the strategies to promote self-care intervention during the resettlement of refugees from the Democratic People's Republic of Korea. So as you're aware, in 1997-2000, devastating famine and chronic healthcare shortage led to a massive population displacement with in South Korea. And what is interesting here is that this population, having faced a shortage of care for quite a long time, have really deeply ingrained self-care habits. And the programmer observed that they often relied on things like addictive painkillers as a common self-care practice. So it's also important here as well to acknowledge that many of the women and girls have lived traumatic experiences and sexual and gender-based violence during the migration, and they encountered stigma and stereotyping in medical setting, which weakened the trust in a healthcare provider. And the historical the history of relying on self-care here presents a window opportunity to introduce culturally sensitive and evidence-based self-care intervention where there is, misguided self-medication practices. The lesson learned here, we're also focused on the healthcare provider. So how can we address healthcare provider bias and integrating cultural competence into the health system to reduce stigma? I thank you.
Dear colleagues, many thanks for your attention and apologize for this abrupt ending as I had to take a call. I hope this presentation was interesting. I tried to cover a wide range of normative documents we have been producing, and you can access them through the QR codes in the presentation. I'm also happy to take any questions you may have. You can write them to me directly at the address indicated at the end of the presentation. I wish you a very fruitful conference and thank you again for your invitation.